So welcome, everyone. I'm very excited to be a moderator here because I get to ask the questions. And if anyone knows me, they know I ask the questions, right? So quite fun. And I'm really excited because I'm going to get to talk with 3 interoperability leaders in our country. So I want to introduce Zoe Barber from the Sequoia Project. And I don't have the big, beautiful intro. But what I want to tell you is Zoe Barber has been around a long time in interoperability. And while she is serving a really important role in our country in getting this national network going, she also has a lot of history in New York in helping with the SHIN-NY. So she knows us well. So thank you, Zoe. Yes. And also David, again, who has introduced himself. Again, many years of experience here in terms of moving interoperability forward. And I also want to introduce Todd, who we know locally. Todd has been part of Healthix since, I don't know, since I was born. So, yeah, so doing interoperability right there locally, you know, where the rubber meets the road. I'm excited to be with each one of you. And I thought it might be helpful for everyone to understand a little bit about what organization you work for, just something about kind of the mission of what organization you work for. So start with Zoe.
Okay, great. Hi, everybody. It's so great to be here. Thank you so much, Virginia, and to the New York HIMSS chapter for having me. I currently am the policy director at the Sequoia Project. And previously, as Virginia mentioned, I worked for NICE and I was at ONC for several years, including in 2016 at the beginning of TEFCA. So I've been doing TEFCA for the full 8 years that it's been around. And at the Sequoia Project, we are a 501c3 nonprofit public-private organization, and we bring together trusted stakeholders from across the industry to collaborate on challenges that are common, across different organizations, and work towards bringing together productive and real-world solutions to those problems. And so we do that under our Interoperability Matters initiative, and we have several work groups that are open to both members and to the public, including information sharing, privacy and security, data quality, pair-to-pair. I could keep going. And then on top of that initiative, we were actually originally formed over 10 years ago to steward the first nationwide health information network, which is now known as the eHealth Exchange. And then a few years later, we, with the help of our founding members, we also launched Care Equality. Both of those organizations today are privately owned and operated. But because of this past experience and our reputation and work among the industry, we were selected in 2019 by ONC, now ASTP, to be the recognized coordinating entity for TEFCA to help to implement and to oversee the program. And that is a large part of my role today as the policy director for the Sequoia Project and leading policy work for the TEFCA.
Thank you very much. And David?
So in the New York eHealth Collaborative, I already described a little bit, and it's very analogous to the Sequoia role as the SDE. We are contracted by the state to look at the policy matters, the strategy for the SHIN-NY, accountability for the state's own investment, how that spending gets used. And then the fourth thing is when there is statewide tech, like the glue that holds the QE transactions together or statewide MPIs, we operate that statewide technology as well.
Todd?
Good. So we're going to describe us as a cog in the wheel, but you can see we're kind of going down. But we're very focused on the community. So we're a regional HIE. We're very large. We're one of the largest in the country, but mainly because of who we serve: New York City, Southern New York State. And as David talked about earlier, our role is kind of pivoting to less of moving data. We connect data with over 9,000 provider organizations, including health plans. and we serve that around 20 million active patients within New York today, which is fabulous. But our role is changing more to focus on analytics. How do we leverage this data to be actionable? How do we get it into the clinical workflow? So it's not just the pipes, the moving of the data, but how do we make it so you can leverage it in actually providing healthcare.
Thank you, Todd. And kind of on that note, I wanted to, and because of the title of our panel, we have the word existing tools and enablers. And I wanted to ask a bit about that and ask what existing functionality and tools do you provide either now or in the near future that really will help enable interoperability?
Yeah, sure. I can go first, and lucky to have been set up a little bit by David describing the TEFCA. As he described, we are a nationwide network, and we are backed by the government, led by ASTP, and that public-private collaboration has really been very beneficial so far. We've also had the opportunity, and a lot. It's been really great for us that we've been able to leverage and to build on all of the successes of the networks that have come before us, and also to learn from the obstacles that they have faced. Today, the TEFCA supports 3 different transaction types. So there's document-based query exchange and push-based exchange, which we call message delivery, and that's done using IHE-based protocols between QHINs. So the QHINs are brokering that exchange. And then also recently this year, we released an SOP to provide support for facilitated FHIR-based exchange. So that is an optional transaction on the network, and participants and sub-participants have the opportunity to connect directly to each other using some of the services of their QHIN, but to connect their APIs directly to each other to exchange using FHIR. And in the first couple of years, as we're growing, we really wanted to kind of meet the industry where it is today, and so we've provided for a lot of flexibility in how those FHIR mechanisms work for authentication and registration and authorization, and we're moving towards having a more scalable and standardized network approach towards FHIR that eventually we hope one day will actually be required of everybody on the network. We also the RCE. We don't store any data, any clinical data, but the RCE does have a directory of endpoints. It's an R4 organization-based directory, and the QHINs have access to that directory, and they can provide that information down to their participants and sub-participants for routing of information and finding where records are. And as David mentioned, we actually have, I believe it was 1,700 connections in the directory today that are connected to a framework agreement, and that represents another 8,000 or 9,000 actual facilities and clinical sites that are parts of those various connections. And that is growing daily. We've had, I think, 3.5 million documents exchanged on the network to date. And that number, again, it's growing exponentially. And then, of course, the reasons for exchange, we have 6 exchange purposes, again, that David showed earlier. Those are sort of the broad umbrella exchange purposes: treatment, payment, healthcare operations, individual access services. And then underneath those umbrella exchange purposes, there are also various use cases, which we like to call our paved pathways, that have more parameters and requirements around a certain exchange purpose. We've recently created a definition for TEFCA required treatment, so it's a slightly more clarification on the broader treatment definition. We also have several use cases under healthcare operations and public health, and hope to build out those paved pathways more over the coming year.
Thank you. David?
Well, I'll focus on what we call the statewide data infrastructure and the data lake that NICE has been building, really started about 2 years ago. The data lake has it's a thin layer, not a great breadth of records, but it is broad. We are trying to have statewide information aggregated in this data lake. It has basically 8 customers right now. Those customers are the 6 QEs, the Office of Health Insurance Programs, or OHIP, our Medicaid team, and then the epidemiologists at DOH. And today that data lake holds lab results, a pretty good breadth of lab results. The source of those is the 6 QE partners, and it holds ADTs, the admission, discharge, transfer data from hospitals, all the hospitals in New York. And we have a lot of test data for the 1115 waiver. Soon that will be, hopefully in January, that will start to be live data. It will be all of the social determinative health screenings that are, what are we calling it? Not SDOH, we're calling it health-related social needs, HRSN screenings, and all of the copy of all of the referrals that get made as part of that program and the assessments. And that data will be available to the QEs to deliver back to care managers so they know what is going on for their patients. That data will go up to OHIP into their own data warehouse so they can do all of the reporting that's necessary with CMS and hopefully convince CMS we need this thing to keep going because of all of the great work that gets accomplished. And then hopefully when we have a hero, it'll be a source system for the hero as well. So maybe that'd be a 9th customer. So we're very excited about that. We'd like to grow the purposes of that data lake. It will include increasingly more of the data the state has already collected, and we can merge those things. The data lake's great big function is to merge data sets, the clinical information with things like Medicaid claims that or enrollment data in other programs, put it together. You can spit it back out as an enhanced data set, or in the case of the epidemiologists, often it will be as a limited data set where they're not maybe getting identified data, but they're getting geographic data and trend data on things like chronic conditions. So we're really excited about that statewide data infrastructure and working hard to build it out.
David, can you just remind me what do you mean by hero?
The Health Equity Regional Organization. It's an organization that will do a lot of the analytic support for that, the big 1115 waiver, the NYHER program. And I don't know that the state has exactly announced who will do that work yet. I know they're in conversations with folks who will do that, and they will inevitably need data, source data, and we want to make sure we're able to provide some of that to them.
Excellent, thank you. And Todd?
So we're kind of like the foundation to the house. If you haven't seen that theme already, I think the QHINs, the SHIN-NY as a whole depend on the organizations that actually collect this data and bring it up. So we've focused a lot on high quality data, making it even higher quality data, terminology mapping, but you talked about the services we offer, and really those are focused on the community that we serve. So as much as we're still in the business of collecting the data today, we really do focus on kind of 3 major areas: data delivery, data retrieval, and data discovery. So within our retrieval, the delivery, we talk about sending out real-time alerts, which is something that the national exchanges don't do and TEFCA doesn't do currently. We focus a lot on providing high quality certified data to do HEDIS calculations for the plans. And then we do work with large organizations just to pump them full of data, which they can do their own analytics. On the retrieval side, we support the basic querying of Healthix across the state, but also within our customer base. We have a clinical portal, which we've really expanded and tried to integrate very close or tightly in with EHR vendors like Epic and Cerner. We've included the PMP, prescription monitoring program, as a really tight integration. And within the context of the patient, Todd Rago in this case, you can just pull the HIE data into your view within the EHR of your choice. So we've really been focusing on how we do that tight integration, knowing that clinicians really don't want to take the extra few seconds or few minutes to look elsewhere. If that's their major tool, you have to kind of be present within their tool of choice. So a lot of focus on how do we best serve our customers so they can serve their patients in healthcare. But those are, and I'll talk about data discovery just briefly. We've been building dashboards really created by our customer base. So behavioral health organizations, which have kind of been overlooked in meaningful use initially, and I think they're getting more attention under the waiver and things that are happening in New York today. Community-based organizations, FQHCs, these are the organizations that are really making a Herculean effort on the ground to change healthcare in New York. So we've built dashboards to really help them access this data more efficiently, in a more meaningful way, so they can leverage it in the work they do. And some of it's on aggregate reports, but also some of it's at the point of care as well. So we're really just working with them. They're the experts. How do you want this designed? How do you want us to supply this data to you? And we're really excited about that type of work that we're doing today.
Thank you, Todd. And you mentioned patients. I want to say that I sent in the paper form to Healthix asking for my data, and I found data that's from when I was very young, a very in-depth amount of data, things I didn't remember. So
it's funny, we don't have a fax machine anymore, nor a copier in our office. We feel like we're going high tech. And we did a year ago launch a patient portal, which I would encourage every New Yorker. It's a free public service funded by the state, obviously. We use Clear for identity proofing, so it's highly secure. We do know who you are as you come in. And it really does open that up. So you don't have to submit a paper form any longer. You can just go to a website, My Health Record New York, and ask for your records. So I encourage you all to take advantage of that.
Very good. So it's Halloween.
Oh, no.
So I was thinking of, trick or treat and interoperability. And, while I would like the treat of interoperability, I spend a lot of time, as well as many of you may, worrying about the trick. What could possibly go wrong? So so the question I have for all of you is, how do we, ensure that data is not inappropriately used, that the availability of data isn't inappropriately shut down, that we don't have, the wrong data, just data quality errors, gaps in data that mislead clinicians because they don't even know that encounter existed, or stale data, duplicate data that overwhelm our clinicians, or just poorly coded data so it's just unreconcilable. So I wanted to ask each of you, how do we tackle these difficult things to make sure that it's treat and not trick?
Yeah, that's such a great question. And I'm really glad that you asked that. This is a topic that we have had no shortage of conversation on over the past year. And in TEFCA, trust is kind of the cornerstone, the building block of the entire network. It's literally the T in TEFCA. One of our QHINs likes to say that without trust, you just have EFCA. And so, we understand and we've heard from our QHIN community and from our stakeholders that when, we are exchanging data at this scale and with partners who may not otherwise have relationships with each other, they may not otherwise know each other, that we really need to have a very rigorous level of compliance. And so we've taken that very seriously, and we've had, again, the support of the federal government to help us. And we've also had our early QHINs and their participants and sub-participants who have participated in helping to shape and influence the policy so far, which I think has really built a very, collaborative approach and a lot of camaraderie and trust within the community of QHINs. So over the past year, some of the things that we've worked on is first tackling the definition of treatment. This is something that has come up a lot over the past year. The HIPAA definition of treatment is very, very broad. It's very subject to interpretation, and it's actually intentionally subject to interpretation. The law was written that way so that covered entities could interpret, locally based on, their compliance priorities, who to respond to, and what they consider to be treatment. And so what we've done in TEFCA is to actually slightly narrow, but really more clarify what treatment is, and specifically what types of treatment you actually are required to respond to. So using the HIPAA definition as a base, we've essentially said, there are certain provider types, covered entities that are doing certain types of activities and making queries that are in connection with or intended to inform treatment with a patient, whether synchronously or asynchronously, but that there actually has to be the intention of having a licensed individual provider, so a human in the room to provide those treatment services. And so, the whole community, again, agreed on this definition, which we plan to expand over time. But then kind of following on the heels of determining that definition, we've now created a vetting process so that we actually have a systematic and structured approach to ensuring that anybody who comes in and says that they are providing this TEFCA required treatment purpose and that they plan to, assert queries for this purpose, that they actually have to go through a process where they can prove their eligibility and prove their use case, and the QHINs have the opportunity to review the evidence and to raise any concerns, and then to have a discussion in an open forum about any of those concerns. So this is something, we are just putting the finishing touches on this vetting process this week, and we'll be releasing something next week. And then we plan to expand it so that every exchange purpose that will have a required response in TEFCA will actually go through this vetting process as well. And we're really hopeful that will help to, again, build trust and, just continue and enhance integrity of the network.
Thank you. David?
Virginia, I might say trick or treat. It's maybe cooperation and competition. And getting the balance right. I think market mechanisms are really important. The topic you had asked me to speak to was government intervention in interoperability, and we're doing that because of market failures, though. And the market failure that worries me is availability of data. We have lots of competition that makes us stronger. We have QHINs in the room who will be competing with each other. We have Sinai competing with New York Presbyterian, right? And that makes better. We have Epic competing. I don't know if there's any Oracle people here today, but they're competing, and that makes us stronger. As the shiny overseers, we want the QEs to compete with each other as well and strive to be better. But it's so tempting to compete by holding on to the data. And that's got to be anathema to us. We have to make the data freed up, and that can't be the thing we compete on. I think that regulators and really those who are in the industry watching, setting the policy, we need to really make sure that we're not competing on the availability of data, that is freed up to be used in ways that benefit patients, as we try to get the benefits of competition in markets.
Thank you.
So it's very interesting. I like some of the themes here. I agree with a lot of what's been said, but healthcare is still a very local thing. So, you still end up going to the providers where you live. You do occasionally go on vacation, get injured, don't come up to New England or Northern New York and fall skiing or something and break your leg. It's not good. But anyway, bringing those medical records together is a problem, but it's really only a small percentage of the healthcare problem of bringing records from away together. I think the majority of the issue is more local, and there is that same challenge locally on how to aggregate those records. But there's this big theme of trust, and I think, I used to work for the HIE up in the state of Maine, and the whole framework, one HIE for the state, small population, about 1.5 million, was built off from trust. It wasn't a requirement to connect to the HIE. It was just something people did for the right reasons. And so I would put out a statement that we want to be careful in New York not to overregulate things. I think it's really important when it comes to privacy and building trust that there are guidelines established. There's good governance and good cooperation. But I think sometimes if you overregulate, people start to lose trust a little bit and feel like they can't gain trust in the system. So it's just something to keep in mind. There's a balance there. If I lost trust as an organization, no one would share data with me unless they were mandated. And we have a large group of ambulatory practices, 5,000 plus out of the 9,000 that send us data, and we can't afford to lose the trust in them and how we handle the data. So I think the governance that David's providing with NICE is really critical to this from the Department of Health, how we establish and maintain that. We mentioned competition. Everyone competes against me. Yeah, we're the ones we're the nonprofits that have been in this business forever. I compete against Epic, Cerner, and how can I do that? Not very well. I compete against healthcare organizations because the tendency is if you do control the data, as David said, if you capture that data, and EHR vendors want to hold on to the data, the hospitals want to hold on to the data, the practice feels like if my data gets into the hands of a qualified entity or an HIE, that they're going to poach my patients and take them away. These are valid concerns. So I agree with David. We do have to free up the data. And in the state of Maine, that's what they did. The largest healthcare systems got together and they agreed not to compete over data. And it's hard because they occasionally want to move off the reservation and say, I want to hold my data tight because that's how I hold my patients to me. But to David's point, how do you treat the patient? How do you treat your customers is what attracts them to you. So if I can bring it back home, to keep people attached to Healthix, I have to provide good customer service and high quality services. I leverage the data we get holistically. And as people know, in New York City, we have the Bronx and Healthix. So the Bronx is a little bit fractured, but bring that data together. We do have services in the state that do bring the data together. And I agree with David, we have to improve those. So the trick or treat for me really quick is, it's funny because the more mature customers say we provide too much data, and you mentioned duplication is a big problem. And so I agree, duplication, how do we dedupe? And as data becomes held or is held by many organizations, how do you deal with that duplication problem? Because we are going to flood the user, the clinician, with too much data, and they only have a few seconds and they only are looking for one thing. So how do we refine the data? So it's kind of a blessing and a curse that we have to solve. I don't know if you put it in trick or treat, but I think too much data is a trick and a treat for HIEs.
One of our clinical experts and informaticians in NYP, Cornell, and Columbia said that the CCDA is kind of like a passive-aggressive standard. And yeah, so my next question is at New York Presbyterian, we're trying to provide IT for New York Presbyterian, Cornell, and Columbia, and interoperability, and we really want to do this well and participate well in interoperability. And so as a result, we are connected to SureScripts, where we get to do direct messaging and e-prescribing. And we also have been a long-time member of Healthix. We started when it was called NYCLIX. I think we were part of another QE, but now I think we just have Healthix. We also have Epic Care Everywhere, and we have care equality, and we have eHealth exchange, and we also have a whole smattering of HL7 version 2 and CDA interfaces to public health. And we're really interested in streamlining things. And even though I'm here as the interoperability witch, I do not have the magic potion for this. But what I would really like to see is I'd like to connect once, and then I would like to participate in interoperability and obtain interoperability in a robust and comprehensive way. And so I want to ask you, because I've heard I want to connect once to TEFCA via our QHIN, and then magically everything else should happen. And I wanted to ask you, like, one, am I out of my mind? Is this achievable? Is it possible? And then two, I want to ask if it is potentially achievable, then what's getting in our way? What are the big obstacles that are getting in our way for New Yorkers to be able to connect once? And how do we get rid of those obstacles? So start with you, Zoe.
I think this might be the real trick or treat question. Yeah, it's a really good question. And, with TEFCA and the frameworks that came before it, like care equality, TEFCA in particular was, Congress intended for it to be a voluntary network, right? It's actually in the law, it's in the legislation that this is voluntary, and that this shouldn't disrupt other, interoperability initiatives, right? So the goal of TEFCA is, not necessarily to replace all of those other exchange solutions, but rather to complement them and to maybe minimize some of the reduce some of the duplication that exists today, and maybe make things more efficient, right? We have a lot of exchange for use cases today, a lot of data flowing, like everybody has said, but it can be really unreliable, right? And really complex and really costly. And hopefully the vision of TEFCA is that there can be efficiencies built in to help streamline some of that exchange. But it truly is not meant to replace everything. I mean, I think as these guys mentioned, right, TEFCA doesn't allow for, or right now it doesn't support the capability for subscription-based alerts. So that's one thing. And, there are other things that, sure, TEFCA has functionality for that could someday, help to reduce the need for some of these other connections, right? We have push-based messaging. It's being used at a much smaller scale than direct right now, but the functionality is there, and we are seeing uptake of that use case for, especially for public health, for submitting electronic case reports and electronic lab reports. But I think it's going to be a long time, and I don't think that, again, that's necessarily the goal, to completely eliminate, all of the other connections. I think the optionality piece, especially with government intervention, as things grow, I think we will see certain federal agencies provide more incentives for the organizations that they regulate to participate in exchange, and provide, business imperatives for those organizations to participate. And we'll also see expansion of use cases that are currently being done, using one-off connections. We'll see expansion of those use cases like healthcare operations and like public health and payment, and hopefully start to see those, more and more become required purposes. But there'll still be the need for other, local solutions, and local connections. And what I want to emphasize also is that if you're looking for, the one solution to rule them all and that one connection, then you should really thoughtfully think about which QHIN you plan to use. right now, especially in the early days, there's a lot of optionality. We talked about the optional exchange purposes. And so QHINs don't necessarily have to offer to their participants and sub-participants. They have a lot of flexibility in the functionality that they offer to their participants and sub-participants. And so it may be that some QHINs are really only using TEFCA for certain exchange purposes or certain transaction types. And so I think it could really vary, and it's really important to take into consideration your business needs and what you want to see from your connection to TEFCA and what you already have, good solutions that are working today for, and you don't need to be replaced by TEFCA.
Thank you. And
well, I want to say yes, Virginia, we're going to, but I don't think the proliferation will stop. Sure, we'd like to have fewer pipes for the raw transport, if you will. I'm a TEFCA optimist. I think I'm very hopeful that working with your primary EHR vendor, that's your major on-ramp for a lot of interoperability. But you said SureScripts was the first network. They do a lot of value add that is not what other QHINs do necessarily. And Todd's described things that Healthix is doing, that it's value add on top of the data. And I expect that to continue and maybe proliferate, and you'll end up needing to have relationships with all of those organizations and data use agreements and all of the things that we do today. Even if perhaps the transport gets easier. We haven't talked about fire yet. How do we get this far into the day and not talk about fire? So maybe transport gets easier, but I think there will be many other organizations you deal with on interoperability, not just interoperability, on value add on top of the data. And I think if Mickey Tripathi really were here, he'd say he wants those to proliferate. He wants more of those things to grow and innovation to thrive.
Right. So my analogy on this front is I've kind of been on a bridge trying to cross to the other side. Now the other side is that kind of the one connection you talk about from a customer perspective. So NYP has just one way to send the data up. But I really feel that HIEs have provided that bridge strategy on being the one connection in the past and currently in many places. Maybe the QHINs will take that over. Right now, HIEs are starting to feed into QHINs as well, up into TEFCA or the national exchanges like CommonWell and eHealth Exchange or Care Quality. But I really believe that there are kind of two customers that we're trying to serve, which kind of poses a challenge. We have public health, and then we have the provider payer community. And I think those are really different, call them market segments. And it's hard to serve public health without having complete data, which means maybe it's non-consented data from a patient perspective. Public health is very broad. Then you have the other world of the provider payer mix, which is, you want to give the individual patient more choice on how their data flows, but obviously you have the same challenges of bringing all that data together, right? That's the challenge. How do you get it all together so you can really serve your patient well, even when they think it may not be in their interest? As a clinician, you may think it is in their interest to know if they have a certain condition, and they're not telling you all their meds, whatever it is. So I think you just keep that in mind. There are two different market segments we're trying to serve. So I think getting down to one connection is really hard. That bridge keeps getting longer and longer as I walk across it. But anyway, it's a very long bridge. Go down to Florida, you'll see a very long bridge.
Just remember the amount of contracts, the amount of risk we take on, the amount we're paying, the amount of work we have to do. That's a lot. So if there's a way to just make the architecture more streamlined, that would be a fabulous thing.
The tough thing for us right now is, at least at Healthix, we're up against Epic, So I would say at Healthix, yes, we could be that one connection, but Epic is your main, those who use Epic, that's their main platform, or eClinicalWorks or Oracle. That is your big conduit for all your connections. So I think that's your challenges.
I'm going to annoy Todd by saying I don't feel like we're up against Epic. I'm a big fan of all of the interoperability they enable. So We want to be complementary, and I know there are those competitive dynamics at times, but I'm a big fan of what the EHRs are enabling clinicians to do.
I'll just add, I think there's a role for everybody in TEFCA. So even if you have providers that are connecting through their EHR systems, they could still utilize their HIEs who may also be connected to TEFCA, and they don't have to be in the same QHIN, but you could still use your HIE to perform queries for certain exchange purposes. If your HIE is providing a service that your EHR is not providing, there is flexibility to leverage both of those systems.
So I'm a little worried about time.
If we have brevity and answers, a couple questions from the crowd would be awesome.
Okay. So I'm going to skip my last and let the audience harass them.
My question is about actually consent. Paul Meyer, Smart Health Network, and maybe building on David's point earlier, maybe for you, Zoe, what's the view or vision for how TEFCA actually deals with individual consent? How do I, as an individual, express my desire or lack of desire to have information shared? And the related question then is, the whole point about interoperability is to actually inform care. A lot of what you need to know about me isn't sitting in EHR data. And so what's the vision also for how TEFCA or other interoperability frameworks actually eventually bring a fuller picture from social care, SDOH, other data actually into that, rather than just being a conduit for kind of traditional EHR data to other EHRs?
That's a great question. Two great questions, actually. And to the first one on consent, TEFCA is built on applicable law. And so it relies on the data holders to follow their own applicable law and the rules that they are required to abide by, depending on where they are, in order to exchange. And so as far as consent goes, if you're at a provider organization or an HIE that requires consent before release, and as we know that's a major issue in New York, then that's the applicable law and that's the rule that you abide by. And there are mechanisms in TEFCA to be able to exchange that consent. So we have standards for exchanging it, and if it's not available, the data holder can ask for that consent to be provided. And then as far as getting all of the data from across the continuum, again, I think that's really where the HIEs play such an integral part of this community, because I think they're the ones that are going to be able to provide those services and provide value and meaning, and aggregate that data and do other things to that data to actually make it meaningful.
In the back right of the room. We agree with that aim for sure, and we are making slow progress. Again, it takes time. We are getting the health-related social need screenings united with clinical data to some extent. We haven't used the word utility or health data utility yet, but I do think that we're trying to make the SHIN-NY function as something of a utility for the state as well. Utilities are governed in different ways, and we could go into that, but it's something I think that would be very valuable to the state, is to have that utility type function to combine data to enhance data.
Dr. Rotem, the AI in Fetal Medicine Institute. I have a question regarding AI. What do you plan regarding the implementation of actionable AI? But I mean actionable AI, it's not medical publications and research, but tools that can be used in patients safely.
I do not. That's the quick answer. I'm hoping to feed data to other organizations that do that. I mean, AI models are voracious data consumers, right? And I hope that interoperability enables others to do much more with AI.
So at Healthix, we do have a project with AI. We're using Microsoft Copilot to summarize the data. And really, it's just the data that Healthix holds. So it doesn't go out to the internet. It's not connected to the internet. It's only connected to our data repository. And as a clinician, not verbally because it's PHI, but you can type in your question, summarize Todd's last 2 office visits or last encounter, et cetera. And it'll go and fetch and summarize. And that's just a tool to make the data more actionable to the clinician, to save them a little bit of time instead of going and looking under different folders. And we've gone through the user interface many times to make it more user friendly, but we feel AI can be an additive tool on top of this to help find that data. So we'll be implementing that hopefully second quarter next year. But we're the first working with our vendor to do this in the US, so we're excited about it. And hopefully it doesn't hallucinate. So
just going to wrap up. Thank you to our panel here.
One more, maybe?
Oh, we have another question?
John,
Okay,
one more.
sorry.
Hi, I'm Matt Bishop, CEO of Open City Labs. We have an AI-powered care plan product. My question is about identity and especially the health equity challenges around accurately identifying patients. Half of Medicaid patients do not have a driver's license. And so while there's a lot of exciting opportunities around like the mobile driver's license standard and being able to kind of prove your identity when you with the scan, have you seeked out, this is maybe more for David more than anybody, partnerships with like the Department of Motor Vehicles or New York City that create their own city identity that could kind of improve that kind of data matching or person identification prospect, because obviously that's central before you even get to consent.
Certainly seeing from disparate sources as belonging to the same person is really central to interoperability. Of course, we use probabilistic matching, as I'm sure you know, and we do use referential data. Most HIEs are using referential data sources. It does get harder when you go from a health system to a regional HIE to a statewide, and then at a national HIE, it is harder.
Yeah.
I don't think maybe others will disagree. I don't think it's the problem it was 10 years ago. It's not like the thing that we're worried about. I think we do a decent job. I tried to work with the motor vehicles department in Maryland, and it was incredibly difficult.
I can imagine.
For what it's worth. I haven't tried in New York.
All right, let's give him a hand. You, Virginia, for moderating a great discussion. Interesting. So conflict, consternation, difficulty. We are moving towards figuring out how to address that, and some of it comes back to views of us, them, right? Everybody, here's the way we do it. Here's how things work. We have some new kids on the block here. The new kids on the block are the QHINs, and partly by being required and partly because of the value that they're going to bring. And it sort of reminds me a little bit of, remember financial networks and ATMs? Well, that was just one use case. There was Cirrus and NICE, and I think Mac it was, right? And they fought, and it was hard, and you had a bank card, and it would work, but not at that bank. Eventually, that went away. Maybe in 15 or 20 years, we may get there. Our moderator for the next panel is Kevin McAvee. Amazing individual. He'll do his own bio as part of his presentation, setting the stage. So we'd like Kevin to come on up. But I will share that even though he'll introduce himself, I wanted to notice that his impressive set of colleges include 2 in upstate New York, Colgate and Cornell, very great institutions. So come on up, Kevin.